Hey people, welcome in. Deeb here with RxPOSED podcast. Today's episode is with Tim Frost, who is a colleague and a former classmate of mine in college. Tim has had a really interesting start to his career where he's had experiences in various areas, such as in regulatory affairs and working as the chief of staff for an attorney general's office in the state of Idaho. He's also worked within the state with other health professions such as medical and nursing, and even worked on the legislative and regulatory side with professions outside of healthcare. He has a very unique perspective, and I'm really excited for you to hear his take on some hot topics, such as overregulation, the impact of COVID-19 on regulations and legislation within pharmacy, pharmacist prescribing, and how do we follow, or what is the best way to look at evidence when it comes to decision making, along with other things like educational gaps and concepts that hopefully you have never heard before. So I'm really looking forward to you listening to this. This is a two-part series, and so you're really going to want to make sure to listen to both so that you get the full experience. Thank you so much for listening. I really appreciate your support. Subscribing, sharing, or liking these videos is extremely helpful, and I sincerely appreciate it. Let's get into the episode.
Welcome to the RxPOSED podcast with your host, DB.
Tim, welcome into the RxPOSED podcast. I'm so excited to have you on today. You and I go back quite a ways. We met in college, but we actually somehow lived down the road from each other and ended up going to the same pharmacy school together. But it's really great to have you on. I want to first start out by saying thank you for being here. I know we're on different time zones and it's a little bit late, especially where I'm at here. And I know it's later for you and you got a family, but tell us a little bit about yourself. Who's Tim Frost and why should the listeners be listening today?
Well, Deeb, I appreciate the opportunity to come on today, and it's a pleasure to be here. To give your listeners a little bit of background, grew up in Erie, Michigan, grew up on a bicentennial family farm, learned the value of hard work, dedication, and integrity at an early age from my grandparents, from my parents, and so really feel blessed by that. Went to the University of Toledo in pharmacy school. Certainly met you there, and awesome opportunity to see your success and see your career trajectory. So congrats on all efforts on that end. After the University of Toledo, I did a post-grad fellowship with the University Pacific University in Oregon. It was a joint fellowship with the Oregon Board of Pharmacy, and so half my time I spent on Board of Pharmacy regulatory affairs, and half of my time I spent kind of on the academia side, teaching pharmacy law and spending some time in their social administrative sciences. After a fellowship, I really dug in deeper to kind of my passion on regulatory affairs and spent some time with CVS Health on their pharmacy regulatory affairs team. Most of the work I was doing was in the West Coast states and, tracked and monitored legislation, in just about every state west of the Mississippi River. Really enjoyed that experience. It really opened me up to how boards of pharmacy do work day in and day out, how the legislature interacts with regulatory boards, how generally other healthcare boards interact with the Board of Pharmacy, and how all of that intertwines. And so was in that role with CVS for almost 3 years and got a call from Governor Little's office in Idaho that they had just issued an executive order to consolidate really 11 former agencies into the Idaho Division of Occupational and Professional Licenses. And so 48 boards and commissions, 11 agencies, with the goal of pulling it all into one. And so there was 12 different locations and 13 different licensing systems, 265 different board members. So just a really unique project and a really unique offering. And the initial conversation was to come in with the Board of Nursing, be the operations manager, integrate into the state agency. I did that for about 6 months and was also the legislative and regulatory affairs manager for the division. And then I was promoted into a bureau chief and then a deputy administrator role, where I was kind of the acting number 2 within that organization, and really loved the opportunity. It was an opportunity to not only oversee 270 employees in the day-to-day and culture, and develop a team, develop a strategic plan, an operations plan to make things better in Idaho, to make government work for the people. That part was awesome, but there was definitely the component which I really loved to lean into, which was the legislative and the regulatory side. And so anytime you have these board members and regulatory boards, they've got rulemaking, they've got legislative opportunities that include statute updates and statute rewrites. And I was very fortunate to be trusted to take on that role and work with the legislature on statute updates and work with regulatory boards on various different statute rewrites. I worked with DOPL, which is the Division of Occupational and Professional Licenses, for about 2.5 years, and then got another unique call and opportunity to go be the chief of staff with Idaho's 33rd Attorney General Raul Labrador. And uniquely with General Labrador's office, there was a real need to transition the entire agency. And so previously there was a 20-year incumbent that was beat out and primaried out by the new Attorney General. And he had a new vision, new strategic plan, wanted to implement a new structure, and went in and helped in that process, and helped the Attorney General hire all of his new division chiefs, change over the organization, get it to be a well-oiled machine and in a good spot from a culture standpoint. And then more recently, I transitioned to start what I have truthfully wanted to do for a long, long time in my life, and that's open my own consulting business. And I named it 50 Elixir, and the focus of 50 Elixir is a 50-state profile to do healthcare government affairs. And the goal from my perspective is to take bold healthcare strategies to solve healthcare problems. The reality out there is sometimes you need a willingness to crash the culture, solve problems, and find out some real solutions towards the issues of our day. And my company as a whole deals with government affairs side of it. Anything that a regulatory board and the legislature would do. We also have general consulting for businesses to just help navigate and grow as a whole. And then we have got a research profile where we work with think tanks and various different academic institutions to make sure we're on the front end of where healthcare policy needs to be, put ideas out there, see how professionals respond to those ideas, and work towards optimal solutions of implementing and solving some of those problems. And so, again, really appreciate the opportunity to be here today, and thanks for having me.
Yeah, no, that is a really, really good breakdown of, what seems to be a rich career so far of working in various areas, and really as a pharmacist showcasing how you can do things both within pharmacy from a non-traditional pathway and also outside of pharmacy from a state and government. And, just generally speaking, working as a chief of staff from an AG's office, that's definitely a very unique set of things that you've experienced. So it's exciting to hear that you've, started this new venture, 50 Elixir. I'm really excited to hear about and see where that ends up going in the future. And, hope that the listeners also check that out as well, because definitely it sounds like you're on a pretty awesome pathway in terms of things that you're going to be offering in the future. So, Tim, you've had a really, really rich experience so far. So, I'd love for the listeners to hear your take on some really important topics today. And I want to start with a question that I've been asking various guests because I know that you have a very interesting perspective. And I'm kind of curious to hear the differences between how people answer this question. So, from your perspective, what do you think are the two most pressing challenges that the profession of pharmacy is facing? And what sort of innovative solutions do you think we could implement? The reason I ask for two is, again, because there's a lot of stuff out there. So we're trying to keep it to two just from a timing perspective and also to challenge you to narrow it to those two. And then on this show, we like to talk about solutions. We're a solution oriented podcast, not just complaining, not just providing the problems, but also offering solutions to those problems. So I'll let you answer this question. I'm really curious to hear what your thoughts are.
Well, I love, Deeb, that, the podcast is focused around solutions. I think that's what we need more than anything in the policy space right now, regardless of your political affiliation, and certainly in the healthcare space and the pharmacy space. There's a lot of noise out there, and people not only need to come to the table and have a conversation, but people need to come to the table with real solutions, not just complaints about what the reality of the problem is. There's probably a lot of different directions I could say of, what are the two most pressing challenges? I think for me, I would break it down. First, the pharmacy profession is dealing with a massive issue of overregulation. And I think the second challenge that I would say, it really dovetails into the first challenge, is more specific to the last 2 years. I think a challenge is making permanent all of the changes that we had waivers of COVID-19. And so as we went through the pandemic, we saw hundreds and hundreds of executive orders, legislative mandates, Board of Pharmacy waivers, broader health and welfare and health authority waivers that direct on the federal, state, and local level that directly impacted patient care and your ability to do things. And, from my opinion, all of that stems from what I think the first challenge is overregulation. But I think more so, we are coming off of the end of a pandemic, and we really need to ask ourselves in the States, have we made permanent the things that were waived during COVID-19? If you were to ask, an overregulation standpoint, like what are the game changers? I think we probably need to take one step back and look at the broader picture. The reality from a pharmacy practice standpoint, when you look at our laws and what I would call statutes in most instances, and then regulations or rules, statutes being enacted by either Congress or on a federal level, or your state legislatures with your House and your Senate. And then rules being promulgated by a particular state agency, in our instance, the Board of Pharmacies. In most states, statutes and rules are 200 plus pages for boards of pharmacy. There are boards of pharmacy out there that, if you combine their laws and rules, there's over 600 pages of content of just regulations. And it is everything from, how you secure your pharmacy, to how drugs are delivered, to what are you as a pharmacist allowed to do? What are you not allowed to do? What are your responsibilities of oversight of the pharmacy? Everything from practice requirements to facility requirements, but down to most obscure things you could ever possibly think of. And so from a broader perspective, I think pharmacy is one of the most regulated professions. And there's even quite a bit of federal regulation if you really want to dovetail that into it. But when you compare pharmacy to other healthcare providers, it's vastly different. If you look at just the sheer regulatory burden that pharmacists have versus physicians, it's not even close. If you compare pharmacists' regulatory burden versus nurses, it's not even close. And even on a national standpoint, we look at, our national associations put forth, model acts and model rules. In pharmacy, the National Association of Boards of Pharmacy has a model act, and that model act is 171 pages. If you were to look at the National Council of State Boards of Nursing, their model act is 30 pages. So I think we have to ask ourselves, like, why is pharmacy regulated so differently? At the end of the day, you have a provider that has a specific standardized education, training, and experience, a set number of years, college and degree that they attained, a clinical competency that they passed to obtain a license within a specific state. But the reality is they have a defined, practice and what their scope is. There's a defined set of criteria of what that discipline is that's surrounding it. And but at the end of the day, when you look at pharmacy and you look at the other healthcare professions, there's clearly a difference. There's a difference in how we are regulated. And I think that's one of the key pieces that, of where we're at right now.
So, very interesting points, and ones that I think none of the other guests have made so far. So thank you for bringing those up. So regulation and overregulation was the first one that you talked about, and you made some comparisons with other health professions. Why do you think people believe pharmacy should be overregulated? Is it a perception that it needs to be overregulated, or is it like, what is the stem? What do you think? Where does it stem from? Where is this overregulation coming from? Is it that, like, I've heard people argue that, well, pharmacy includes more than other professions. Like, we compound, we have facilities, we have all these things that are in pharmacy that other professions like nursing don't have, right? Nurses are not compounding, generally speaking, from like a sterile compounding, etc. So is it from that? Like, what do you think? Where is this stemming from?
Steve, I think it's a good question. I think ultimately at the end of the day, the differences as they would get explained, I think by most pharmacists, is some of the points that you made. So you're not only regulating the professional, you're regulating the facility. The reality, though, is there's regulations of hospitals. There are regulations of skilled nursing facilities. There are regulations of urgent care. So the places that a physician works, the places that a nurse works, so the places that a psychologist, PT, OT, dentist, every single one of those places has facility requirements. And so I think in theory, when you have the conversation, pharmacists are quick to say, well, we have facility requirements, and that's what makes us different. That's why we have hundreds of pages, and another profession might just have 30 or 40 or 50. But at the end of the day, I think the short piece of it is probably a little bit of just personality of pharmacist. And I mean that in a positive way, not a negative way. Very attention-oriented, detail-oriented profession, very black and white thinkers. Type A personalities in most instances. And that's what makes pharmacists incredible when it comes to understanding drug therapy, pharmacotherapy, the vast amount of information that a pharmacist can withhold and retain, and help our patients in whatever variety of settings and ways that we're utilizing our education, training, and experience. And so I think that level of specificity in probably the training and the knowledge expertise, I think it naturally has progressed over time of when those pharmacists are on a board of pharmacy, they also want that same black and white explicit language within a law or within a rule. And, I think it's a little bit of pebbles in a stream scenario. It probably started off with, most of our boards of pharmacy are, 100 years or more old at this point. It probably started off with a very simple practice act. It was probably very broad, those initial apothecaries and drugstores. But I think over time, maybe by personality, that specificity, more pebbles got thrown into the stream. And eventually, at a point, you throw enough pebbles into the stream and you now have a diversion of the water. You've got a dam, you've got an overflow, and there's a real blockage that all of a sudden starts to impact practice. It starts to impact your ability to innovate. It starts to impact your ability to think about more creative ways to solve problems in healthcare and take care of your patients. As things become more complex, the more pebbles and the more regulations that are there, the reality is just there's less and less flexibility. And, I think that less and less flexibility starts to, quite frankly, it increased costs. You don't have the ability to have new business models. But I think it increases frustration on pharmacists and on patients because the care that they want to see and how they want to see it, oftentimes in states, they're not able to deliver that type of care. And so I think the short end of it, we have historically as a profession probably regulated with, what would be called bright line regulation, very clear, very explicit, often overstated multiple times in statute and in rule. And I think other healthcare providers have been very clear that they've implemented what's called a standard of care approach. And a standard of care approach is an approach by which you don't specify every single thing that a provider can or can't do. It is what a reasonable and prudent pharmacist would do in a similar situation or a similar setting. And it's a regulatory model that has specific tenets that are connected to patient safety. But at the end of the day, the goal of a standard of care model is to make sure law is not static. And law is dynamic based on the clinical ability of that particular pharmacist. And so hear me out on an example. If you have a state that has a bright line way of regulating pharmacists, the reality is every single pharmacist in that state might approach a problem, a business, a patient with a different solution, a different type of opportunity. But the law is going to be the ceiling by which they can perform their practice and take care of their patients. In all instances, it's the ceiling for what they can do. In a bright line regulation model, you are setting a standard that says every pharmacist, every technician in this state is the exact same. Here's your ceiling. And I don't think that's a reality. I think just by human nature, between everybody's clinical education, training, and experience, and you layer in the reality of technology, this gives an opportunity for what I would call a really dynamic clinical ability of every single person. And so from a regulator perspective, you've created the ceiling, but from a pharmacist perspective, what if you could go above that ceiling and do better things for patients? What if you could go above that ceiling and create a new business model that would better facilitate care? What if you could go above that ceiling and you could significantly lower the cost of prescription drugs? What if you could go above that ceiling and bring new opportunities that ultimately will solve issues? And I think that's the short-sightedness of bright line regulation and a set standard. I think in a standard of care model, and I think both physicians have proven this, and dentists have proven this, and veterinarians have proven this, and nurses have proven this. I hate to say it, I think pharmacists are one of the last professions to really not fully implement this across the states. But a standard care model has proven that these individuals can work within their framework, work within their education, training, experience to provide the care at which they're trained to provide at. And I think that's always best for patients. I think it's always and it's best for providers. It's going to prevent burnout. It's going to prevent the fatigue and problematic workplace conditions. When you're happier in your day-to-day life and you're able to provide, you're able to perform at your optimum, you're going to feel better. You're going to act better. You're going to interact with people better. And I think if pharmacists are feeling better, they're performing better, patients are going to be better off. The healthcare system is going to be better off. The outlook of pharmacy is going to be better off. And I really think the future of pharmacy, a key solution to overregulation is starting down a standard of care model. And it looks a lot of different ways, everything from prescribing to collaborative practice to prescription adaptation to shared services. There's so many things we could explore in the regulatory world that needs to be optimized according to standard of care. But I really think that's the future.
So you made a couple of interesting points that I want to highlight and also, make sure that I was catching and people are catching properly. So one of the root causes, it sounds like, could be a historical or an evolution of personality, pharmacists generally speaking. And I think this is actually evidence-based. I think that they've done some studies which I can link to if I find those. I'll put those on the screen for people. Some studies that have actually looked at more recently personality traits of people going into pharmacy school versus medical school and other types of health professions. So some of it could be a personality challenge, or not even a challenge, or just a difference in personality where pharmacists or people who go into pharmacy prefer things in a very black and white manner. They want to know what can and cannot be done. They want to know that the I's are dotted, the T's are crossed, right? So that's one piece of it. Number two is that there is, generally speaking, an evolution of the practice of pharmacy. There's things that have been added to the practice of pharmacy over time that I think, have compiled, and maybe that has increased our practice acts and things that people have wanted to regulate. Number three sounds like, from a bright line rules perspective, and tell me, because I'm not sure if you pointed this out, but I want to maybe hear your take on it as well, if not. But from a bright line rules perspective, that makes the ceiling very visible to people of what you can versus cannot do legally. And so, from a regulatory perspective, from a board or an inspector or whoever's doing the discipline side, their job and the way that they're looking at things is more clear, right? They know, did you do something wrong or not, based on how the rules and laws are written. But you speak of the standard of care model, which other health professions have adopted and have had for years, it sounds like. And pharmacy hasn't really moved towards that, or maybe there's parts of pharmacy that are in there and definitely parts that are not. But the standard of care model is connecting the dots of people's clinical and technical skills and abilities and knowledge to their ability to practice and at the height of which they can practice. So it's taking the disconnect of what you learn in school and the skills and abilities that you have and putting it to use rather than having that ceiling, right? Because everyone's ceiling is different.
Mm-hmm.
My ceiling in terms of what I can do as a clinician is way different from yours, is way different from another pharmacist. We're all going to have different experiences. So, we should be exercising our judgment in those cases. So all those things adding up can lead to overregulation. And then I want to revisit the last point you made, which we don't have to rehash, but all the stuff that happened during COVID is an example of people taking out regulations and making exceptions for you to be able to take care of those patients in an emergency situation. And what happened? We proved as a profession that we can do it. People weren't out there bodies in the streets all of a sudden because an executive order came out, to my knowledge, generally speaking, because of removing that, allowance or allowing somebody in pharmacy to do X, Y, and Z. So that is actually evidence. Would you argue with that that's evidence to what you're saying, that COVID and some of the things that we've seen over the past few years of the exceptions that were allowed is actually evidence to go and show that maybe we don't need all these regulations?
Deep, I think you're exactly right. I think it's a real question every pharmacist should be asking themselves right now at one of the lowest points in the history of healthcare during COVID-19, when Americans were at one of our most vulnerable points, in community pharmacy, in hospital pharmacy, in every possible setting. We waive requirements at that most vulnerable point. And I think we should be asking, if we were willing to waive these quote unquote safety requirements in our most vulnerable point as a country, is that not a rebuttable presumption that we absolutely should be making them permanent? Isn't that a real argument that maybe these requirements weren't as connected to patient safety as we thought they were? And in addition to that, if you look at what was waived across the country for pharmacy, and we could get into requirements related to prescribing, we could get into restrictions related to drug administration. There were things that were waived related to point of care testing. There were waivers related to staffing requirements in what the ratio of a pharmacist to a pharmacy technician is. There were supervision waivers. There were notification waivers to boards of pharmacy of when you have to notify, how much you have to notify, how much communication there needs to be between a business and a board of pharmacy. Almost every section of a typical practice act for a board of pharmacy, if you combine all the states and you looked at every executive order, every waiver that came from board of pharmacy, almost everything touched one of the sections. There were waivers on compounding. There were waivers on notification. Like, we could go on and on and on. That in itself, the fact that states in our dire time had to honestly spend the first 50, 75% of their executive orders from governors on pharmacy related issues, I think it's proof that there's overregulation. Just period. And something you said earlier, I think is important to maybe revisit on kind of the ceiling part. Western medicine, for physicians and nurse practitioners, I believe has grown and created something that is really magnificent that not every other country has, because they don't have to think about the regulators. They're not thinking about inspections and annual inspections or off-the-cuff inspections. They're not thinking about what is my ceiling again from statute? What am I allowed to do with this patient? What am I allowed to say? And I think for a pharmacist, you think about the laws and rules every single day, multiple times every single day. And so I actually think it's a good question for us as pharmacists to say, what would the profession be like? Like, what innovation would we have from a drug standpoint, from a pharmacotherapy standpoint, from the services that we could provide to patients? Like, if we could take that time every day that we spent on worrying about, is this legal or is this not legal? And we could refocus that on building our business or taking care of our patients or thinking of new innovative solutions, like, where would we be as a profession right now? And I would argue, I would contend that is one of the biggest differences between pharmacy and medicine and nursing is pharmacists are spending way too much of their daily time wondering whether they are falling within what's legally allowed in their state or federally under their requirements. And it's a problem we have to solve. And it's directly connected and was absolutely exploited by COVID-19 on how many different waivers that came across the states from governors and from boards of pharmacies to get out of the way.
Yeah, no, that's a really good point. I mean, I like the picture that you drew with, if you take every state add up all the different exceptions and put them all together as one, there could probably be something from almost every section of what we see typically within our, our laws and rules, and generally speaking, the areas within pharmacy. So that's actually a very good example. So, we've talked about challenges. You've provided some innovative solutions, but I'm curious to hear about some evidence-based advancements in practice. It could be for pharmacists, it could be for technicians, it could be for students, etc. What are like two or three, if you could really focus in on of those advancements that pharmacists and technicians have maybe evidence behind, maybe that some that are talked about daily, maybe some that are not talked about daily. You can kind of pick and choose what you want to. And why should legislators, boards, or others consider those areas? I think one of the big things, one of the big philosophies that I've grown to appreciate and hopefully can continue to drive home with listeners is evidence-based lawmaking and evidence-based medicine, right? We use evidence when we are doing clinical practice. We want to use guidelines, studies, etc., to make those to help us with clinical decision making. And it goes the same way when we talk about our practice advancements. So tell us what you think those two or three advancements that have some evidence behind them would be.
Deeb, I think to start off to even unpack this, I, I would first change up the framework. Boards of pharmacy need to put the burden of proof, and regulators in general, whether that be a legislative body or a regulatory board, the burden of proof for keeping a requirement should be on the person that is advocating to keep that requirement. And so I think for years, the pharmacy profession has been in this very unique tailspin where we are demanding, in order to inch the door open even just a little bit further in a state or on one particular issue, that we demand a randomized control study, randomized controlled trial, or maybe multiple randomized controlled trial to prove that this is safe. And I actually think we should be asking the opposite. I think every other profession asks the opposite. And I think we need to first be saying, is there any legitimate study, research, anecdote that can be supplemented by some legitimate objective data that says this is going to cause patient harm? At the end of the day, if we are going to add a restriction on a profession, there needs to be demonstrable evidence that is going to cause patient harm. It shouldn't be the opposite, to where it's a mother may I situation until you prove that this is absolutely safe and you have years of evidence to prove that it's absolutely safe. And one of my favorite examples of this, and I think you've heard this before, and there's a peer-reviewed published study out there where it talks about a randomized, do you need a randomized controlled trial for somebody to jump out of an airplane or a helicopter with a parachute or without a parachute? And I think the short piece of it is maybe in that instance, the impact if you jump out of a helicopter without a parachute. Not every possible thing in life needs to have peer-reviewed evidence to say this is absolutely safe. And as a result of us proving that it's safe, the government will now allow you to move forward. I really think it needs to be opposite. And, Adam Thierer, a researcher from the Cato Institute, George Mason, and is now at R Street Institute, wrote a book called Permissionless Innovation. And I really think he tests this theory across many different professions, many different scenarios, of healthcare to pilots to the transportation industry. And, permissionless innovation is essentially the framework where we really should look at life and how we interact society as things are permitted up front. It is an open door policy. And then when we recognize that there are legitimate public safety issues out there. We start to narrowly tailor our regulation towards solving those issues. And I think the pharmacy profession, I don't know when it was, but I think you could make a strong argument between the 80s and the 90s. We all of a sudden switched. We switched from generally having a hands-off approach and then narrowly tailoring and solving issues when they came up to completely closing the door. And every pharmacist, moving forward has to go to the state legislature, has to go to the board of pharmacy and ask for every single new innovation, every single new opportunity to help solve patient problems. And so, when you ask me, where can we go? I think on a broader perspective, we need to change the way we think about evidence-based regulating. And the burden of proof needs to be on individuals to keep regulations, not burden of proof on individuals to prove that it's safe from the get-go. I think it is a founding fabric of the United States and the core freedoms as a country that we're authorized to do these things first. And if and only if there's a legitimate, objective patient safety need at that point, then we regulate and we narrowly tailor that regulation towards solving that issue. I think, where do we start with, a less restrictive approach, new innovation? I would say evidence-based pharmacist prescribing is a huge, huge opportunity. And it's a huge opportunity that's still incredibly restrictive. I know you've published on, the continuum of pharmacist prescriptive authority. Our colleagues, Dr. Adams and Dr. Weaver had, initially wrote an awesome paper in 2016 to set that framework up. Kudos to you on the recent update to that. It was a really good paper that breaks down, different types of pharmacist prescribing across the states. And, it first starts with, collaborative practice, or what we call dependent prescribing. And collaborative practice is broke down into patient-specific collaborative practice and population-specific collaborative practice. And so the reality is, let's just use collaborative practice. Before we even get to other models such as independent prescribing, just in collaborative practice, a patient-specific model is near inoperable in a community pharmacy setting. So, I mean, as a profession, you see pharmacists go to the state legislature, go to their boards of pharmacy, put on their advocacy hats, talk about how they can increase access through prescribing, even via collaborative model. And the restrictions are so much so that when they actually pass the law, you can't implement it in a community pharmacy setting. And Deeb, when I say this, like, it's easy to say of like, yeah, but how much of a reality is that? Almost 40 states still have a patient-specific collaborative practice agreement. Delaware was finally, I believe, the 50th state, the last state to get a collaborative practice law in place. Guess what type of collaborative practice law they passed? Patient-specific.
Yeah.
Almost can't be utilized in 80% of community pharmacy settings. So what access issue did we solve? What patient scenario did we solve? I mean, don't get me wrong. Will it help in institutional settings? Yeah. Will it help in some ambulatory care settings that it's, uniquely a physician or a nurse practitioner is immediately there and always there? Yeah. It is a step on the continuum, but it's the beginning of the continuum. And, you move to population-based collaborative practice, and, Washington State was the pioneer of that state. I believe it was 1978, 1979. They've had a population-based collaborative practice agreement for over 40 years. But Dean, my question for you is, if Washington State has had a population-based collaborative practice for 40 years, why have we had 49 states since then implement a law that's more restrictive.
Yeah.
Is it based off of safety?
No. I think most people would answer, and this is just me based on my experience, most people would probably say the problem is the medical associations and the medical groups who push back and the politics that gets involved. And that's truly why we can't get to that next level, because we're facing so much resistance on the political side and we just don't have the lobbying power / dollars that they do. That's truly why we can't get past that step. At least I think that's what people would say if you were to ask those who have been involved in maybe some efforts. Thank you so much for listening to part 1 of episode 4 with Tim Frost. To continue the conversation and discussion, check out part 2, where we cover more interesting topics and Tim shares his insights. Thank you for your support and listening.